So I'll briefly introduce both of you as you find your seats. You should have a mic. Yep. Their full bios are in your program book, but Dr. Kamal Pohar, hopefully you were able to join us yesterday and heard him speak yesterday at some of our summit sessions. He is a urologist specializing in treating patients with genitourinary cancers, particularly bladder cancer, at The Ohio State University. And effective January 2026, he will be professor and inaugural chair of the recently established Department of Urology at the University of Cincinnati. So Beacon will find you there, and we will make sure that we have a presence with you there as well. So thank you so much again for joining us. And Dr. Tareq Salous is a medical oncologist from Indiana University School of Medicine, where he leads research in genitourinary cancers with a focus on bladder cancer, and serves as principal investigator and co-investigator on several clinical trials, which we'll hear a bit about today. Thank you very much. So this session is going to be an interactive dialogue, so less PowerPoint, so you can rest your eyes a bit. I'm going to pose a question to either Dr. Pohar or Dr. Salous, or both. Either or both of you can feel free to answer. For about the first 40 minutes, we'll leave the last 20 minutes or so of the session for Q&A from the audience, from all of you, so please jot your questions down. The good news is there's a lot to cover. There have been a lot of advancement. There's a lot of research. We won't be able to cover it all in a 1-hour session, but we will do as much as we can, and Beacon's website will hopefully serve as a resource for you for whatever we're not able to cover, as well as our experts will remain in the room for a bit after this session as well. This session will also be recorded and posted on our website, so don't feel that you need to jot down every single note. We'll make it available afterwards. So to start off, as Beacon is currently celebrating our 20th year, I'd like to ask both of you, whoever wants to kick us off, in the past 10 to 20 years, what would you say has been the most transformative advancement in bladder cancer care? Switch it on. Just push it. Yep. There we go.
Can you guys hear me? Okay, I think you can. All right, perfect. So I think it's very, very interesting to be a bladder cancer doctor these days because of all the advancements we have in bladder cancer world. From a medical oncology standpoint, I think one of the best or one of the most transformative treatments we have these days is the introduction of immunotherapy. I would say maybe 10, 15 years ago, we had very limited options when it comes to advanced disease or muscle-invasive bladder cancer. So we only had, things like surgery or radiation therapy or, traditional chemotherapy. I think immunotherapy changed the way we treat all type of cancers: skin cancer, lung cancer, kidney cancer, bladder cancer, all kind of cancers. And immunotherapy made a huge improvement in the outcomes in the world of the advanced bladder cancer. So it's definitely, one of the most, impressive, I would say, advancements. The other part is the genomic sequencing or the genomic testing or knowing more about the genetics of bladder cancer. Many times these days we can run tests where we can learn a little bit more about the mutations that drives the cancer. And sometimes that open doors for treatments, or we can kind of know that this is a more aggressive tumor, or we can treat it in a different way. And every few months or every few years we have kind of new medication that targets one of these specific mutations. So if I want to pick two, maybe immunotherapy and genomic sequencing.
Yeah, I'd have to say it's so difficult to really focus on one thing, but it's just been it's been so exciting for the last decade. It's the number of advances, but really a fairly simplistic concept that I think has really changed in this last decade is BCG. We've even kind of gone to a level of realizing that the importance of giving the maintenance course of BCG, which we never used to do not that long ago, how impactful that is. And then we've come to a consensus that we know, unfortunately, the drug fails patients, a percentage. And we've come up with new definitions now in the field of non-muscle invasive bladder cancer of when has BCG really failed us. This term BCG unresponsive, terms like BCG exposed, BCG refractory. And this is helping the field, and I think we're going to get into some of these conversations today. So I think this concept of BCG therapy, we understand it with a lot more precision.
Thank you both. And before we talk a little more about BCG and some of the newer options, I want to back up and talk a little bit about detection. And how close are we, or are we close to a reliable, non-invasive early detection test, such as urine or blood-based biomarker?
Maybe I'll start with the urine. So, it's a long-standing concept of wanting to detect cancer cells in the urine. And urine cytology is the classic test we've used for decades. It has value, but it has limitations. So there are numerous types of tests that have been developed, looking at a single protein in the urine, looking at a panel of proteins, or looking at the changes of the cell in the urine. Those tests have not really impacted us very favorably, but it's moved now to the level of we can do a lot more than just look at a protein or a cell in the urine, but you can measure numerous proteins. You can measure a whole panel of the RNA. You can look at what's called methylation of the DNA, a lot of biologic principles. So it's called multiplex testing. And we're getting closer and closer, I think, to getting better biomarkers. There are certain aspects of bladder cancer care and non-muscle invasive bladder cancer where some of these biomarkers today can have an impact in select situations, but are we ready globally to use these biomarkers to replace a cystoscopy, to diagnose bladder cancer? We're not there, but I think there's a lot of promise in the field. There's many more sophisticated ways to study the urine that are being evaluated, so I'm optimistic.
I kind of agree. I mean, we are getting closer to these tests, but the science is not there yet. So hopefully in the near future.
Thank you. So let's talk about BCG. We know BCG is the earliest form of immunotherapy to treat bladder cancer. It's still standard of care. But what about for non-muscle invasive bladder cancer patients who don't receive BCG or can't receive BCG, are termed BCG naive? Can you give us an overview of what's going on in that space? And I think you have a slide if you want to refer. Can we pull up the first slide?
Oh, excellent. Thanks for that. I'll go to the second bullet point first. If there's no availability of BCG, so that's a difficult space, and we don't have a lot of good options today where we have good knowledge or we have good effective therapies if you can't access BCG. But certainly chemotherapy has been an option for a long period of time. There are national guidelines put forward by urologic cancer associations during the BCG shortage. So we have good direction that if BCG is not available, which chemotherapy drug should be utilized, what's its effectiveness. So chemotherapy is an option. But importantly, that second bullet indicates that we've recognized that BCG, it's a very good drug. It's been around a long time, but it's far from perfect, both in terms of effectiveness and availability is worrisome. That if it's not available, what are we to do? So there's clinical trials now in this space, and this bridge trial it's a very important trial in our field. It's now closed. It recently closed. It's a trial that accrued almost 1,000 patients to the trial. It'll take some time to get the data, so it's comparing BCG to a chemotherapy option given in the bladder. It's 2 drugs combined, gemcitabine, docetaxel. So we don't know, is that an effective regimen? We will know moving forward in the future, so that's an option. And the other thing I put on the slide that I think is important is BCG, as I mentioned, it's a good drug, but it's not perfect. So can we do better? There's a number of trials now that are completed. Some of them have been reported. It's taking BCG and it's adding another immune therapy agent to BCG, an immune checkpoint inhibitor, which we've been talking about a lot at our meeting yesterday. There were many topics that brought up checkpoint inhibitors. And so BCG combined with them. So there are 3 trials that are now concluded. One of them has been published. The other 2 will be presented at a major meeting in Europe coming up here in the next couple of weeks. So we're going to learn about them. And there's a lot going on in this space.
Thank you. And we know when BCG is available, it doesn't always work. And so sometimes BCG fails the patient. And an ongoing critical research topic is, what do we do for BCG unresponsive patients? And there has been a lot of progress in that space. We may have heard recently a new FDA approval for what's called Inlexo, or formerly known as the Pretzel. It's a new drug device. What else is there available, and what are we doing now that there are so many options to determine what works best for the patient?
So I have a slide that I put together. It's the BCG
the next
unresponsive one. Do we mind putting it? Thanks for doing that. I gave a talk yesterday, and we kind of talked about risk stratification for non-muscle invasive bladder cancer. We highlighted the high-risk category, that BCG is the standard of care. And so this is kind of advancing that one step further, that I kind of stopped the discussion yesterday. At that point, optimistic BCG will work. So clearly it doesn't, as we're discussing in some individuals. The drug fails us. And so the cancer is unresponsive to BCG. So there are a number of agents on this slide. The ones that I put up, 4 of them, they're all gone through clinical trials. They've been studied in a manner that's acceptable to clinical practice, the FDA, where we have knowledge of their efficacy. So I've listed them here. And so Keytruda, Adstiladrin, Anktiva, and now TAR-200, the Pretzel that Rebecca was bringing up. So these are all options we have available. So thankfully, there are several options that are available to us today that if BCG is not working, the cancer has come back, specifically carcinoma in situ, with or without other forms of bladder cancer associated with it. There are several drugs that we have knowledge of how they work.
Which is wonderful that we have all of these new drugs, but maybe a follow-up question for you or Dr. Salous as well is, what do we know about which one to select and when? And if one doesn't work, when do we try the next one? Are there studies looking at sequencing now that we have more options that didn't exist previously?
Yeah, that's a great question and such an important topic to discuss. So clinical trials, we heard from the group yesterday, they're done, they're done in specific ways. We talked about phase 2, phase 3 trials, single-arm trials, randomized trials. So there's many options available. We'd love to know, is one better than another? So there's only one way to really know. You compare the drugs, in a clinical trial. You randomize patients, one drug versus another. So that hasn't been done yet. So that's something, there's a lot of conversation at the level of the FDA and other experts in the field. Are we ready to start doing randomized trials in this field? So that's important. But this is the year 2025, 2026 is around the corner. We don't have trials. We have to make decisions today, imminently. What are we going to do? So there's many factors that one would need to consider with these drugs. First of all is, what are the results of the drugs? What's the effectiveness or the efficacy? It's hard to compare one to another. Again, we don't have the proper trials, but we do have evidence about, how effective are they, so we can talk about that. Side effect profiles are really important. So that's another important topic as we're making a decision about which drug should we consider. What are the side effects like? That can have some bearing on what an individual's current bladder function is like. So depending on the side effects, will that drug be tolerable in that given individual's bladder, given its current functionality? So one needs to compensate that. The schedule on which how the drugs are given, like can you give it once every 3 months, or do I have to come in every week for the next several weeks? Or, what's the interval of my coming in? Obviously, we all like less is best. Nobody wants a drug put in their bladder through a catheter over and over again if you can avoid it. So that's another factor you would balance against how effective is it, what are the side effects, and finally, how is the drug delivered? Is it through a catheter? Is it through an IV? So, there's many types of things you have to consider. Naturally, it's complicated. Everything I said, it sounds like a winding road. It's complex. But these are all the factors that come into play, and what's transportation like? What's the support network for the individual? If you're traveling 2 hours to a center to get the therapy and you need to come every week, is that feasible? So I think all of this, it's a complicated topic. We talk about it every week in the clinic, and it's a long conversation, and rightly so. There's a lot to talk about. It's very directed. It's what's best for that individual and their family and their caregivers, and what do they want.
Thank you. And that's a great segue when we're thinking about what works best for the patient and patient outcomes. There was a large study who recently has results, the Salous study, that is doing exactly that, looked at patient outcomes, an observational study, so not a randomized clinical trial, comparing radical cystectomy with bladder-sparing therapy for non-muscle invasive bladder cancer patients who are at highest risk. What did we learn from that study, and how do you think that might help shape conversations now between patients and their care team?
So I have another slide. You could tell I love slides. I have another.
It's your last one.
It's my last one. So this is the other side of the equation. This is such an important study. I have to applaud the principal investigator, Dr. John Gore at the University of Washington, to really do the heavy lifting. Beacon had so much to do with this study. This is a quality of life study. This didn't have to do as kind of, what was really being studied as the primary thrust. It was kind of looking at individuals with non-muscle invasive bladder cancer in whom the BCG drug failed. You're at a very difficult decision point of, should I have my bladder removed, or should I try another therapy? The therapies I put on the last slide. Should I try another treatment? And so we would often think everybody would rather try a drug. Who wants their bladder out? Nobody wants a major operation, and then you're going to build me some new urinary system. And we would assume that quality of life for someone to keep their bladder was probably better. Everybody wants to keep their bladder. So what this study did is, it started with an effort at the Bladder Cancer Think Tank. The group, we met with the think tank a couple of years in a row and then separately to find out what patients and their caregivers, what's important to them about quality of life. What are factors of quality of life that are important to you? And so questionnaires were built into this nationally funded clinical trial run at many centers. And we were measuring what quality of life is, and somewhat surprisingly, the hypothesis was wrong. What we assumed is bladder sparing provides a better quality of life. That's not true. It was equivalent when you looked at physical functioning between those individuals who chose radical cystectomy versus those who chose bladder sparing. But all of those secondary endpoints on that study, it's on the slide, your emotional well-being, your stress level, your anxiety level, financial toxicity, your bowel health, your urinary health, it was all in favor of radical cystectomy on these really validated questionnaires given to patients who chose cystectomy versus bladder sparing, they had better quality of life functions with radical cystectomy in all of these other categories as secondary endpoints. So we were surprised by this. We had to look at the data second time, a third time. Are we sure the data's right? And the study's going to come out in a major impact journal shortly. It's been accepted. And so not that everybody now should go and have surgery, but it's another thing to factor into what I just said a moment ago on the last slide, that long, winding road of things you would consider. This is now important. Quality of life outcomes. How do people feel choosing one of the two options? So, you know, it's all incredibly important information, but complex, maybe somewhat overwhelming, but really important information. This all needs to be discussed if we're going to be really educated and to make good decisions that are best for us.
Thank you. Yeah, I think that'll continue to shape future studies and conversations about this as well. Before we move into talking about the muscle invasive space, I just want to pose to you, what do we still need to know in the non-muscle invasive? Where should we focus our research efforts now?
Well, I think there's just so much we need to do. You know, it's endless. As you know, the more thoughtful you are as you kind of think about medical practice, you know, you see patients every day in the clinic, in the operating rooms, in the hallways of the hospital, and you're having conversations. You realize that there's so much we could do better. You know, there's so many deficiencies. We've come a long way. But in terms of what we could do better is patient selection. So this term of, I think, you know, something top of mind is biomarkers. You know, starting to learn better who's going to respond to a certain treatment. You know, we all want to know that. You know, nobody wants the treatment to fail us. You know, it's disappointing for everyone, the patients, their families, caregivers, the treating physician, the pharmacist we heard from yesterday, the stomal nurse, the dietitian. Everybody is disappointed when the treatment fails us. So learning, you know, what treatment is truly going to be the right one for us, I think that's critical.
Thank you. So Dr. Salous, I want to talk a bit about what's going on in the muscle invasive disease space. And we know the standard of care has been chemotherapy plus bladder removal. And just prior to this session, you and I were talking about some potentially very exciting new results coming out of the ESMO conference. How might those, can you tell us what they are, and how might those change the standard of care?
So I would say 5 or 6 years ago, we used to use immunotherapy only when patients have metastatic disease, when patients have stage 4 disease. The field is strongly moving these therapies up front. So, you know, before surgery or after surgery in patients who don't have metastatic disease. And the idea is, you know, we know these therapies work very well. Maybe if we use them earlier, patients will live longer, less chances of, you know, cancer recurrence. So that's one of the, you know, there was a major, I would say, phase 3 clinical trial that was reported earlier this year that used a medication called durvalumab before surgery. So this is in the neoadjuvant setting where patients are getting the traditional cisplatin-based chemotherapy plus an immunotherapy medication called durvalumab. And we learned from that study that patients did significantly better if they got the immunotherapy before the surgery. They lived longer. They did, you know, when we look at their cystectomy samples, they didn't have as much cancer as compared to the patients who did not receive the immunotherapy. So this became kind of our new standard of care where we're using immunotherapy plus the traditional chemotherapy before patients get surgery and sometimes after the surgery, again, to improve the outcomes. This is kind of brand new news, is being presented, I believe, this weekend in ESMO, using another, newer therapy called enfortumab vedotin, which is an antibody drug conjugate. I call it a smart chemo. So this is a chemotherapy drug. It's basically like a rocket that is attached to the chemotherapy, and that rocket takes the chemotherapy and dumps it inside the cancer cells instead of everywhere. So this trial I was just talking about is using immunotherapy, so Keytruda or pembrolizumab, plus that newer chemotherapy. And the trial was very, very positive, and is being reported, as I said, this weekend. I don't know the numbers. They didn't announce the numbers yet, but I think it's probably going to change our standard of care in the very near future. So the use of these newer therapies earlier on rather than just in the stage 4 setting is kind of the theme. And I won't be surprised if these medications even move to the non-muscle invasive world in the very near future as well, because they work very well and they are less toxic than our traditional chemotherapy medications.
Thank you. And you mentioned neoadjuvant treatment. Are there markers to determine what patient would benefit from that versus not, when to administer and not?
That is a very, very difficult question, I think. I wish, sometimes I know which patient I can say, well, this is the patient who would benefit from the therapy. We know some of the patients who don't benefit from therapy, specifically patients who have certain variants, or, they have the non-urothelial carcinoma variants, specifically squamous cell carcinoma or plasmacytoid or some of these micropapillary variants. They tend to not respond to chemotherapy well. So in many cases, we say, well, let's not just waste our time with chemo. Let's just move towards surgery, and we will learn more about the cancer after the tumor is removed. And we could potentially consider either immunotherapy after, or maybe chemotherapy if we learn something different. There are certain markers, like something like circulating tumor DNA, that is becoming a very hot topic in the muscle invasive world too. I just want to spend maybe a few minutes on this. So this is where we take a sample from the tumor. We isolate the DNA of the tumor, and we identify unique portions of the DNA of that tumor, and then we create a specific test to look for the DNA of the cancer in the bloodstream. What does that tell us? It basically tells us, okay, well, this cancer is not just in the bladder, it's hovering in the bloodstream as well, and we probably need to be more aggressive, and we probably need to use chemo or immunotherapy before we do the surgery. So this is becoming a very, very kind of important marker, I think, these days, especially in the muscle invasive world. And I think it's, again, may make it to the non-muscle invasive world too.
That's great. I was just going to ask you about ctDNA. So you beat me to it, but can you share about the modern trial?
Yeah, so the modern trial is I think, one of the best adjuvant trials we have these days. What adjuvant means is we're doing therapy after surgery to reduce the chances of the cancer coming back in the future, or recurrence. So what the trial does is basically, after the tumor is removed, we do this circulating tumor DNA test. And if the test is positive, we know that maybe some cancer cells are left behind or hiding somewhere in the body, and we want to be very aggressive. We want to do some therapy after the surgery. On the modern trial specifically, it's immunotherapy. So it's either one immunotherapy or two immunotherapy drugs. But if the test is negative, the trial is basically trying to, kind of ask the question is, do we actually need to give adjuvant therapy? And again, the trial offers two options. One is more immunotherapy or more therapy versus no treatment and just close monitoring with getting this test very, very often, along with scans, and acting at any point the test becomes positive. So I think it's answers some of the very important questions we don't have answer to right now. Is, okay, well, if the test is positive, should we be more aggressive and do two therapies rather than just one? And if the test is negative, do we actually need to do more therapy? So I think it's a great trial. I'm very happy. I think the trial is enrolling very, very well across the United States. It's almost available in all big centers in the U.S., and I think it's one of the best trials we have for adjuvant therapy these days.
And how does a patient go about receiving ctDNA testing? Does it have to be part of a clinical trial? Can all patients receive it, or should they?
So it is available off clinical trials. I tell my patients it's a new technology. It's a great test. We have strong, very good data that it works very well, specifically in the muscle invasive world. But we don't know the significance of the test. So the nice thing about doing it through a clinical trial, we will have a scientific answer to what the test means. If it's positive, does that mean that the cancer will be back? And should we be more aggressive? Should we do more therapy? Should we not do any therapy and wait until the cancer is back and treat it in a more aggressive way? So all of these questions are being asked and hopefully answered through the clinical trials. But if you get the test off the clinical trial, you're going to end up with some of these questions that you don't necessarily know the answer for. And sometimes it can add a lot of anxiety to the patient as well. Knowing, okay, well, my ctDNA is now positive, but I don't know what to do about it. So I personally really encourage my patients to get it through, for example, the modern trial. But if for some reason they can't, and they are interested in the test, it's available. You can order it. It's called Signatera, and the company who do the test is very, very good about it. They reach out to patients when it's due, and they sometimes can come to your house and actually, draw the blood from your house, which is, wonderful for patients who live far away from big cancer centers.
Thank you. So moving into the advanced or metastatic space, a few years ago we heard a lot about the results of the phase 3 trial that looked at EV Pembro in combination, or EV in combination with Pembro versus chemotherapy, and it has really changed the way that advanced patients are treated. What do we know about those results now that it's been approved? It's been a couple of years. What are we seeing in terms of patient outcomes?
So I think Pembro EV is a great regimen. This clinical trial, the 302, was reported in ESMO in 2023. They basically compared Pembro EV. Again, Pembro is an immunotherapy. EV is the antibody-drug conjugate, or that smart chemotherapy I explained earlier, with the traditional chemotherapy. What we learned from that study, that patients who have advanced disease, they have stage 4 disease, if they got the Pembro EV, they live significantly longer, almost double, the overall survival. Like we're talking 32 months versus, 15 or 16 months with the traditional chemotherapy. Side effect-wise, I think it's generally easier than the traditional chemotherapy for patients to tolerate. It still have its own kind of side effects and problems, but in my opinion, it's much easier compared to the traditional like cisplatin or carboplatin-based chemotherapy. And the idea of using a therapy that targets the cancer cell is becoming more and more popular, and I think it's going to continue to improve in the future. We have a lot of medications currently they're being tested in clinical trials to target similar proteins on the cancer cells or other proteins that I think will be available for patients in the very near future too.
And so you just touched on targeted therapy and precision medicine. Are all patients eligible to have their tumors tested, or is this mostly an option for advanced or metastatic patients?
So the testing itself can be done basically on everyone, like even in the non-muscle invasive setting. The problem is many times we face is insurance coverage. These tests are expensive. Unfortunately, sometimes the insurance companies would not pay for the test if the patients don't have advanced disease. Sometimes, for unique kind of cases where the insurance says no, and I truly think it's a very important information that I need. I try my best to work with some of these companies that do the testing for us and say, well, we really need this test done, but the patient's insurance is not willing to pay for it. Can we find a way around it? And many of these companies, honestly, they have like great programs where they can support the cost of that, or they can basically do the test for us for free. In the metastatic setting, I think it's very, very important. It's one of the first things I talk to patients about. We have several medications that target some of these mutations that we potentially learn about when we do the testing. And we have trials and we have approved medications that target these mutations. So learning about these mutations up front can absolutely open doors for clinical trials and open doors for other treatments. So I almost order this test on all my patients with advanced disease, period.
And last question before we open to the audience, but what do we know, what has the research shown us about the risks or benefits or the outcomes for patients who do receive targeted therapies, that had the testing done and receive a targeted therapy? How do their outcomes perform compared to those who have not?
So these targeted therapies, they're very exciting because, again, it's the same, it's the concept. We have a mutation or we have a protein that we can target on the cancer cells and hopefully, take care of the cancer or improve the outcomes. That's great. But unfortunately, these medications are not, benign. They have their own problems. We have, in bladder cancer, we have several medications. For example, we have a medication that targets a mutation called FGFR3. We have a medication that targets a protein called HER2. We have many medications that being investigated to target, Nectin-4, similar to enfortumab vedotin. And each medication has its own kind of problems. I think unfortunately we will have to do the trials to know about these problems so we can improve these medications. But being on a clinical trial is absolutely okay because you're getting a very supervised treatment. These protocols are usually very well written. They are we go over them many times. We have multiple committees that make sure that the medications are given in an appropriate way. Anytime a patient has a side effect, it's reported to many levels. So when you're on a clinical trial, even if you get some of these side effects, obviously we hate that, but I think this is the only way we can learn about these side effects and improve these medications.
Thank you. Well, I want to make sure we have enough time for our audience to ask our experts some questions, but thank you both so much, Dr. Pohar and Dr. Salous, for sharing this information with us. I wish we had more time. There's so much to cover, but I think we've just begun to touch the tip of the iceberg here. So we have some mics in the audience if we have questions.
Thank you, doctors, for the information. I'm going through BCG. You may have heard before. I've been going for 2 years. I'm in a 3-year course right now. And one concern I have, and it might be just imaginary, but the elasticity of my bladder, because I have very severe reactions now. I urinate blood and I urinate tissue sometimes, scabs and different bloods and stuff. So over the time, since I have such a reaction, does this alter the elasticity of the bladder permanently, or am I going to bounce back pretty well? Because I have frequent urination issues. They've lasted this whole 2 years, and pain and such.
Yeah, it's kind of I think it's akin to what we were just talking about. Unfortunately, therapies can have side effects, and so it's kind of the drug has clearly been effective for 2 years now, which is wonderful, but side effects are building. It varies in everybody. It's hard to say what the trajectory will be moving forward. Will the symptoms be stable? Will they get worse with the next round of therapy? When therapy is done, will it stabilize? Will it improve? Unfortunately, it's hard to predict in a given individual. Only time will tell. But I think what's important is I'm sure your care providers are monitoring the types of symptoms you're having really closely, because there are ways to try to manage that situation, that if the side effects are becoming significant, there's ways that can be modified. So I think it's good that you're collaborating with your providers and kind of making sure that it's safe to continue on the therapy and balancing its benefit.
I actually can talk really loud. I probably don't need a mic if I had to. You refer to EV as a smart chemo, and I know that it was approved by the FDA, I think you said in the year 2023. As it's being implemented now as an approved standard of care, I want to make sure I word the question right. Now that you have a population that's different than the clinical trial population, is there an organization or how do you track what you've learned from sort of the, I'm going to say in quotes, the real population, not just the clinical trial? Because now you're using it with different age groups, different scenarios, and you're implementing it every day. There has to be something new you learn from it that comes outside of the clinical trial. And if there is something, what is it?
That's a great question, and I completely agree. The clinical trials, they tend to, hopefully reflect like the patients we see in clinic, but unfortunately, they sometimes don't. Our patients are unique. Each patient is unique. Each patient has their own medical problems. They have their own comorbidities. They have their own, medications. They take several other medications with the medication. So it's important to know whatever reported on the clinical trial does not necessarily mean that's it. These are the side effects. If they were not reported, it can't be. The companies have kind of several ways of tracking these side effects, working with the doctors, and they continue to follow these patients on the clinical trials as well. And I tell you from my experience, I've learned about EV specifically a lot since I started using it in 2024. And some of the reactions my patients had, I asked the company or I asked, my colleagues about, and honestly, like sometimes we don't know. Like we really don't know why patients have these side effects. I'll give you a very, very common example. This is not something unheard of on EV. People have a very weird hyperglycemia, high glucose levels with EV. I asked this question to many, many people, how this happens, what's the mechanism of action of that, and really no one knows. So yes, the clinical trials absolutely do not represent what happens in reality. Some of these side effects were reported in the clinical trials, but every day we learn something different about these medications. And there is a kind of continued kind of reporting system to the companies and to the FDA about these medications. And that's why you probably hear about medications being withdrawn from the market after several years of being in the market and being used on patients. To the best of my knowledge, we've not seen any really bad, kind of side effects with EV so far to the point that we think it should be, taken out of the market. But definitely there are some side effects that were not reported before.
Yeah, and selfishly, I'm more concerned about the success rather than the side effects. Have you seen in reality that it's done way better than your expectations?
Mm-hmm. So I tell you, I've started using EV, Pembro EV specifically, after that presentation in 2023. I think it was FDA approved in January or February of 2024. And I had some really, really great outcomes. I have patients who've been on Pembro EV since that time, and they have no evidence of cancer on their most recent scans, on their ctDNA, on PET scans, on everything we have. So I definitely have seen some patients who overperformed the averages that were reported on that clinical trial specifically.
Fabulous. I love that. So my last follow-up question, I'll hand the mic back forever, is, they propose I believe it's 9 cycles. Does that mean those patients that have had success, is there any standard that you guys have established that says, okay, it's ongoing, or we just keep moving? I mean, what happens after 9 cycles?
So the specific trial, the Pembro EV in the metastatic setting, they used Pembro up to 2 years, and they opened it for EV. You can continue to get EV beyond 2 years. My experience is most patients can't continue to take EV mostly after a year of therapy because of some of the side effects of the medication. So we often have to stop the medication. But I'll tell you the other part of the story. Sometimes I had to stop the treatment after 4 or 5 cycles of treatment. And patients have been on basically no treatment or a treatment holiday since then, and they are doing very well. We get scans, we don't see the cancer, we get the circulating tumor DNA, we're not seeing evidence of cancer recurrence. So some patients absolutely may stop the treatment less than 2 years, but we really don't know. We were just following what they did on the clinical trial because this is kind of the closest scientific way of doing it. But in reality, most of the patients can't do these therapies forever. And I don't think we should do these therapies forever because they have a lot of problems. They're smart, like it's a smarter chemo, but it's not the smartest chemo ever. It still causes a lot of problems like skin issues, hyperglycemia, lung issues, kidney issues, all of the above. So we have to be careful of how long people stay on these treatments because they can cause problems, sometimes more severe than the cancer itself.
Yeah, I just make a brief comment about that. So following up on that question is when the clinical trial is concluded, often the work is not done. There's often real-world registries that then happen where the drug has now been studied on a clinical trial with very specific boundaries related to how patients get in the trial. But then, as we said, we want this to go to the whole population. And do we see the same effect in the whole population? So there's registry studies that go on, and it almost invariably happens with every agent that gets approved. So there's just the work continues to help answer that question.
Dr. Pohar, I have a question about the observational study you talked about bladder sparing versus radical cystectomy. And as a person who's 4 years post-RC with an Indiana pouch, those results don't surprise me at all. But if you had asked me a month before surgery, those results would have surprised me. So were there specific, I know you said it was very broad and observational, but were there any specific data points, whether it's about anxiety or any specific data points that really struck you that tell the story?
The study is very detailed. It's a quality of life study. So there are numerous validated questionnaires that were administered to patients that looked at multiple aspects of how one measures quality of life. And so the thrust of the study was called the physical functioning domain. And so your ability to function in life. And there's a number of questions that live under that. That was equivalent between the two. So whether you had your bladder removed or you tried another therapy when BCG didn't work to save your bladder. But then many other questionnaires focused on anxiety, depression, stress levels, urinary health, financial cost to you, financial toxicity. And so I found most of that surprise, not every one of those parameters, but they're in favor of radicals having your bladder removed. Those groups of patients had better quality of life outcomes in all of those categories I brought up. So, all of that I think was a surprise to us. The study was designed in a way where the hypothesis or what we thought the outcome would be, because every study has to have you kind of have to predict what do you think the outcome would be. You have to have a hypothesis. We thought everybody would prefer to have their bladder retained, and that wasn't the case.
I'm just curious, how many of your patients do you both have participating in trials?
It's hard for me to quantify a percentage, but what I have to say is this. Surely in my career, what I've learned is even in spaces where we think we're doing well, like BCG naive, let's say, for instance, it's important to have a trial, you know, at every opportunity of every face-to-face interaction we have with a patient. So naturally, I have the privilege of working in a comprehensive cancer center, and we're very invested in opening clinical trials, but literally we have a trial open in pretty much every single space I walk in. There's no reason I can't bring that up with every patient we see in clinic. We have trials.
I kind of completely agree on this. The way I look at it, like from a medical oncology standpoint, we try to basically have a clinical trial option in each setting. So for example, in the neoadjuvant setting before surgery, a bladder spurring option, adjuvant option, and options in the metastatic setting as well. And we try to be picky sometimes because we don't have the resources to open all the clinical trials. We have to make sure we kind of look at our resources and make sure we open trials that we think is actually going to help people. We have the resources most of the times, but we don't have, like all these clinical trials open at the same time. So we just have to sometimes pick.
And if I could just say, in terms of the clinical trials available, every clinical trial is not a therapy. So, it's important that we have trials that are not all about therapies or therapeutic trials. There's many non-therapeutic trials that are just as important that we're opening, whether it's an imaging study, whether it's a biomarker study, these urine tests we're talking about. So there's a lot of trials and information that don't always have to be about a treatment.
Thank you.
I have maybe one last question for you both before we close, and that's going back to these new results that we're going to see come out of ESMO in the muscle invasive space with EV Pembro. What would it take or how long before these results then translate into standard of care and into an available option for a patient?
I think first we have to see the data because the company announced that the trial was positive, but we don't know like the details of that. I suspect it's going to be a very positive trial, and I suspect it's going to make it to the standard of care quickly. Just based on the previous experience with Pembro EV in the stage 4 kind of settings, I think it was FDA approved within a month or two after the data was published or was available for us to review. So I don't think it's going to take a lot of time. And the nice thing about this specific trial is we have now some experience with Pembro EV from stage 4, kind of setting, so we can take that and start applying it in the muscle invasive world. I remember when ESMO presentation, when that ESMO presentation 2 years ago, many doctors didn't feel very comfortable with these medications because they've never used EV before. So I used to get sometimes calls from, from colleagues and saying, okay, well, I've never given this medicine. Like, what if my patient has this? What if my patient has that? And they didn't, sometimes they avoided the medication because they don't know what to do with the side effects because they've never used the medications. I think this stage has passed because we've had much more experience with the medications now. And I think probably the urologists also had some experience with these medications. I remember when immunotherapy came out back in like 5 or 6 years, when we started using immunotherapy in the muscle invasive world, many urologists didn't feel very comfortable operating on patients after immunotherapy or before immunotherapy. And slowly this became very common and people felt very good about it. So I think we're learning quickly and hopefully we'll keep our pace with the science.
Thank you so much. Well, I want to wrap up and thank all the patients and caregivers for those really excellent, thought-provoking questions, and thank our two experts, Dr. Pohar and Dr. Salous, for spending time with us on your Saturdays and sharing this cutting-edge information with us about what's new in bladder cancer research. So thank you very much.
Of course. Thank you so much.